Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. For this lecture, we will go through the overview of pregnancy, labor and puerperium or postpartum phase. This is part 1. Okay, in this part 1, I will cover the physical and physiological changes that occur during pregnancy. I will concentrate more on musculoskeletal system, cardiovascular, GIT, renal and endocrine system, pulmonary and reproductive system. During pregnancy, various symptoms may develop, and many of these are widely accepted as normal part of uncomplicated pregnancy. And the anatomical and physiological changes that accompany a normal pregnancy are profound, and most of the system of the body will adapt to these changes. Awareness on the physiological adaptations during pregnancy is important for us to understand to ensure we can provide effective management. And body changes during pregnancy occur on both physical and physiological aspects. In this topic, I will cover musculoskeletal functions and movement, posture, cardiovascular, respiratory, renal system, gastrointestinal, and endocrine system. Let's go through the common anatomical or physical changes that occur during pregnancy. There are massive or extensive literature research articles that has proven or reported multiple anatomical or physical changes that occur during pregnancy. Pregnancy will result in anatomical changes or conditions which could have an impact on women's ability to engage in physical activities. And the most significant pregnancy-induced changes is the expansions of the uterus. This is to accommodate the growing of the fetus and products of the conceptions. Okay, and the uterus will expand from a strictly pelvic organ before 12 weeks to become an abdominal organ for remainder of gestations. And the expanding of the uterus will cause an anterior cephalad shift in the center of the gravity and progressive lumbar lordosis. So that is why most of the pregnant lady will develop lumbar lordosis, and this is part of the compensatory. And lumbar lordosis lead to low back pain in 40 to 50% of the pregnant women. To compensate for lumbar lordosis, pregnant woman, the body will increase the anterior flexions of the cervical spines, which will resulting in kyphosis. And prominent kyphosis can be associated with paresthesia and motor weakness over the distributions of the ulna and or median nerve. So overall research reported that most pregnant women will develop increase in angle of both lumbar thoracic curvature and anterior pelvic inclinations. Next is the excessive weight gain. Avoiding excessive weight gain is important because 20% weight gain will increase the biomechanical force on the joints, and by as much as 100%, thereby increasing the risk of joint injuries during certain physical activities. Physical therapy and exercise that to strengthen muscles at major joints may prevent or minimize the risk. Okay. These are some articles that shows physiological and anatomical changes that can occur during pregnancy. Next, due to hormonal changes, pregnant woman tends to develop joints laxity, but this can be varies from one individual to another. And most of pregnant women will experience widening of 10 millimeter of pubic symphysis beginning at 10 to 12 weeks of gestation. One in 37 women will also experience pubic symphysis regional pain, which is occasionally incapacitating. And for instance, this study, Cheney et al. 2019 reported that laxity of the metacarpophalangeal joint increased by 11% from first to the second trimester of pregnancy and stabilized until delivery. So we know that during the first to second trimester, there is a lot of hormonal changes that occur, so which affect the ligament laxity and also joints, suggesting that laxity reach its maximum plateau changes at the second trimester. This is based on the Cheng et al. Consistent changes were also being reported by Chu et al. The second study here, where they found that joint laxity and compliance decreased in the coronal plane and in the posterior directions, while compliance increased in the anterior directions. Okay, that is for joint. An elevated level of estrogens and relaxin during pregnancy increased flexibility and remodeling of collagen in the knee and other joints. This alter the joint biomechanics due to lasting changes in the joint laxity may cause supraphysiological stress on the musculoskeletal tissue. Additionally, increased joint laxity will lead to cartilage stress of a greater magnitude or in different distribution. It has been suggested that increased joint laxity during pregnancy is responsible for knee problems such as chondromalacia patella. So sometimes some signs and symptoms or conditions can occur like chondromalacia due to excessive weight or due to changes in the joints laxity or ligament laxity. Next is the peripheral edema. This is most common and resilient manifestations in pregnant women. Its etiology includes the retentions of sodium and water, and it is associated with decreased plasma osmolality and increased venous pressure due to inferior vena cava compressions. So as there is a retention, the inferior vena cava also get compressed, as well as functional calf muscle insufficiency. The calf muscle pump also become insufficient. Next, this study found that pregnant women tends to experience alteration on their walking parameter due to postural changes. Even though there is no significant changes on their gait parameter on the kinematic aspect, this study found there is significant variance on the center of gravity, which has been related with the body mass gain. Next, this study found that there is increase in trunk hyperextension throughout the pregnancy. So there are possibility that the changes on the center of gravity is due to the increase in lumbar lordosis and kyphosis. Okay, these are the findings. It's proven that the increase in center of gravity inclination angle was likely associated with the relative mass gain, but not much on the changes by the structure itself, like kyphosis or lordotic, or changes on the spine structure. Few studies have acknowledged the reductions of physical condition among pregnant women, mainly during third trimester of pregnancy. Weight gain and alteration on their physical conditions lead to complaints of pain, discomfort over the spine and lower limbs, which decrease the energy to perform daily activities. Greater fatigue levels, they sleep more and decrease mobility and work capacity. And musculoskeletal problems have been shown as a major sources of disability and loss of work among pregnant women. Okay. This has been reported in this study. For example, this study, overall the results suggested that low back pain is the most common musculoskeletal conditions that affect pregnant women, followed by back pain, hand, wrist, and hip pain. And some of the studies reported that pain around the lower back and pelvis is collectively called lumbopelvic pain, or LPP, and it is common symptom during pregnancy that lower the quality of life in many pregnant women, and even after pregnancy. Next is the cardiovascular changes. This table is summarizing the cardiovascular changes that normally occur during pregnancy. Actually, you can get most of this information of this lecture from Jarvis and Nelson article here. Okay. During pregnancy, normal metabolic processes are altered to accommodate the needs of developing fetus. The protein content of the maternal body tissue will increase and the carbohydrates accumulate in the liver, muscle and placenta. The cardiovascular changes will start during the 5th week of gestation or during 5th week of pregnancy and last until about a year of after delivery. Commonly, we can see in pregnant women, the cardiac output will increase around 40% and partly due to increased stroke volume and partly to increase the heart rate. And when there is only 30% increase in the body mass to be supplied by the maternal blood. Okay. On top of that, a few articles suggested that maternal heart rate increase early in pregnancy. It start peaking and plateauing in the 3rd trimester because the fetus has stopped develop and most of the pregnant lady will have plateau body mass at, in 3rd trimester. The blood volume also increase, okay, during pregnancy by around 40 to 50%, and the systemic vascular resistance is markedly reduced. Despite the drop in the systemic vascular resistance, the mean arterial pressure falls minimally during pregnancy as the decrease in the systemic vascular resistance. Okay. This is in to match the magnitude by the rise in the cardiac output. Next, the vascular tone. The vascular tone also will fall due to high plasma progesterone concentrations, and the blood flow to the uterus is increased by several folds. During pregnancy, the anatomy of the upper airway undergoes numerous changes, multiple changes. You can see that the pregnant woman will develop large neck circumference and there is increase in edema of the upper resistant respiratory airway involving the pharynx and larynx. Therefore, intubations in a pregnant woman can be difficult and smaller endotracheal tubes may be needed. In addition to that, the blood vessel in the nose undergo vasodilatation causing capillary engorgement. Consequently, nose bleeding, rhinitis, and nasal congestions are common. There is a significant increase in oxygen demand during normal pregnancy. The oxygen consumption will increase up to 30% and the metabolic rate will increase by 15%. The functional residual capacity, which is the volume of air remaining in the lung on normal passive exhalations, will reduce by 10 to 25%. The FRC comprise expiratory reserve volume and residual volume, both which will decrease during pregnancy. There is also increase in minute volume by 40 to 50%, mostly due to an increased tidal volume rather than increase in the respiratory rate. This maternal hyperventilation will cause arterial partial oxygen to increase and arterial partial carbon dioxide to fall. This is with a compensatory fall in serum bicarbonate. A mild fully compensated respiratory alkalosis is therefore normal in pregnancy. Commonly, they will report that the arterial pH is at 7.44. And during pregnancy, the kidney will increase in size approximately 1 cm due to increase in vasculature, interstitial volume, and dead space. The renal collecting system starts to dilate from the first trimester, resulting a combination of the effects from progesterone and the compressions of the ureters at the pelvic brim. Okay. This may cause what they call a condition hydrouteronephrosis. Next, ureteric compressions leads to urine stasis, increasing the incidence of urinary tract infections, nephrolithiasis, and pyelonephritis pyelonephritis during pregnancy. At the same time, the bladder will lose tone. Therefore, pregnant women complain of increased urinary frequency, urgency, and incontinence. These symptoms are compounded in the third trimester as the fetal head start to engage in the pelvic region. As consequences of the renal vasodilatations, renal plasma flow and glomerular filtration rate or GFR will increase compared to non-pregnancy. Usually the renal vasodilatations and filtration rate will increase around 40 to 60 and 50 to 85% respectively. Common urological symptom in pregnancy will induce urinary frequency, nocturia, urgency, and stress incontinence. Actually, up to 95% pregnant women will complain frequency, the cause of which appears to relate to the bladder functions and impact of the gravity on the uterus. Frequency to urinate. There is also increased risk of infections secondary to urinary stasis. The cause of urgency and incontinence can be multifactorial. Both uterine pressure on the bladder and hormonal effect on the urethra suspensory ligaments are also being affected. So next, nocturia is related to increase in sodium and water excretions during the night in pregnancy, and in part this is due to mobilizations of dependent edema. As pregnancy gestations increase or advance, the uterus expand and displace the digestive organ, especially stomach and intestine. Okay, so akan ada uterus expansions. Next is the esophageal sphincter. The tone will also decrease, so most of the internal organ will lose their tone. The tone will decrease, and this factor may predispose to symptoms of reflux as well as nausea and vomiting. Additionally, there are changes in gastric emptying time, okay, during pregnancy, with increased transit time throughout the GI tract due to increased level of progesterone hormone. Therefore, constipations and heartburn are common symptoms during pregnancy sebab dia punya stomach tu lambat empty, lambat kosong. Next is the changes in the liver biochemistry may occur during pregnancy. So that is the changes, physiological changes that occur on GI system. Next is the endocrine system. During pregnancy, endocrine system undergoes adaptation to cope with the increased metabolic demands of the mother and the fetus. Okay, so metabolic system also work hard during pregnancy. The hypothalamic pituitary axis is crucial in regulating many key metabolic activities during pregnancy. Levels of many hypothalamic releasing hormone will increase. The pituitary gland comprising anterior, intermediate, and posterior lobes. In the anterior lobe, there is hypoplasia and hypertrophy of the lactotropes during pregnancy. The thyroid gland undergoes significant changes in physiological and size. Thyroid biochemistry is markedly altered during pregnancy. Therefore, pregnancy can also lead to iodine deficiency. The causes of these are active transport of iodine from the mother to the fetus and placenta unit. So the mother will commonly show signs and symptoms of increase in iodine excretions in the urine. What are other changes apart from what I've mentioned? Pregnant women can also experience skin changes, glucose metabolism changes, protein metabolism, lipid metabolism changes, and calcium metabolism changes. Okay, thank you guys. That was my last slide. So please go through Google Site and YouFuture for any additional information for this code, whichever that suit you well. Any question, you can send me email or post it in YouFuture. Thank you so much.